I am Alan Schroeder. I'm in the Division of Hospital Medicine and Critical Care at Stanford, and I am the Stanford PI for PEDSnet. I am so thrilled to be here today and to follow that incredible session this morning. I'm very appreciative of everyone from MCHRI, Mary, Tony, Nata, who's been incredible in terms of helping us put this together. And we were asked today to come to talk about PEDSnet, and I'm thrilled to talk about PEDSnet, and we will talk about PEDSnet, but I felt like you would be better served to put PEDSnet in the context of all of the other incredible data sources that we have here at Stanford, which can oftentimes be quite confusing to researchers. So I'm going to provide you with an overview of PEDSnet, and then the rest of my crew over here is going to provide you with some overviews of some of these other data sources. Natalie Pageler is going to talk about using EPIC and Slicer-Dicer and the local EHR data, and also talk a little bit about Cosmos, which is up-and-coming national EPIC data. Natasha Flowers is going to talk about STARR-OMOP. Esther Velasquez is going to talk about PHS data, including insurance claims data. And then Chris Russell is going to talk about some of these nationally available data sets, mostly inpatient related data sets regarding pediatrics. And then at the end, I hope to have enough time to have a panel discussion. And what I ask of you guys is to think about your own work and think about what questions you have regarding which of these data sets might work for you. And I encourage you to bring those to the microphone and get free advice. These are our speakers. Natalie Pageler will follow me. Natalie is known to most, if not all of you. She is our CMIO and a clinical professor in pediatric critical care medicine and has really been visionary in bioinformatics space. She'll be followed by Natasha Flowers, who knows the nuts and bolts of PEDSnet and EPIC and OMOP incredibly well. She's one of our senior data scientists. She'll be followed by Esther Velasquez from PHS, who has a social work degree and is an epidemiologist and a senior research scientist at PHS. And then Chris Russell, lastly, I'm thrilled to say, is our newest recruit in our department. We stole him from CHLA. He's an associate professor in pediatric hospital medicine, does work on children with medical complexity, and has done quite a bit of work with some of these national data sets. So we're here and talking about this because the current state of clinical research in children is weak. I just finished 2 weeks on service, one on the PICU, one on the hospital medicine service, and it's really dismaying how many decisions I have to make that lack evidence. And we don't have randomized trials in kids. We have some, but we don't have as many as they do in the adult world, and we lean on adult data, or we lean on less robust and rigorous observational data. Because of this, we are leaning towards increasingly using large databases as an attractive alternative to answer some of our questions. So we sit around in our conference rooms and we talk about our ideas and our potential research questions. We think about all the different ways we can go and what the data sources may be, but we have these questions. What are the pros and cons of this data set and this data set? How do we access them? Who owns them? Does it cost money? If so, how much? And along the way, there are all these silos. So many of us are working in parallel rather than together. Just as an example, the critical care division contributes a whole bunch of our data to something called virtual PICU systems led at CHLA, and that same data is being given to PEDSnet. So there's sort of these duplicative efforts going around here, and getting us all together to talk about this becomes so important. So what is PEDSnet? PEDSnet calls itself a National Pediatric Learning Health System. The mission, purpose, and vision are listed here, and just sharing the last part of the vision statement, 2023 vision is to be the premier multi-specialty national pediatric clinical network for conducting research in routine healthcare settings. These are the 11 institutions that participate in PEDSnet. It was started by folks at Children's Hospital of Philadelphia and continues to grow immensely. This is a heat map on the lower right here showing where our patients come from. Really a great geographic representation across the United States. So we use something called a common data model. I'm not a data scientist or bioinformaticist, but what this basically means is that a lot of these institutions store data somewhat differently. And so before the data gets into PEDSnet, it becomes more similar so that it can talk with data from other institutions. And that's what people like Natasha spend a lot of time doing. We have a wealth of data in PEDSnet. It is almost the entirety of the EHR. I say almost because one of the things that it doesn't include, and we get these questions all the time, is progress notes. And that becomes somewhat of a limitation for certain types of projects. There are some creative approaches and solutions that are ongoing right now around natural language processing. Keith Morris has been involved in some of that, but not yet. We do not yet have full access to progress notes unless you want to go and pull charts at your own institutions. But we have labs, we have lab results, we have vital signs, we have anthropometrics, we have all demographics, we have outpatient and inpatient encounters. Again, this is across 11 institutions, and I'll give you some numbers in just a second. There are some administrative efficiencies that make this a little bit easier than trying to launch your own multi-center project. Who here has tried to launch a multi-center research project? Oh my gosh, it is so head-bangingly frustrating, right? I mean, with the data use agreements, the multiple IRBs, it's really, really hard. And so one of the advantages of PEDSnet is that's all embedded in the network. 12 million patients, Mary mentioned that early this morning. It's a lot of patients. 11 partners, we mentioned that already. Lots of physicians. Primary care practices. So this is a really nice benefit is a number of the institutions like Stanford, like CHOP, like Cincinnati have extensive primary care networks within their children's hospital. It's part of their children's hospital. So we can tap into that data as well. I can brag about PEDSnet successes because I've really had nothing to do with them. I've been in this role for about 9 months, and the bulk of these successes predated my arrival. But $150 million in grant funding, 90 plus published studies thus far. This is a smattering of the various ongoing projects and the funding agencies. You can go to PEDSnet.org, not hard to remember, and read more about these various projects. This is our team. Keith Morris was supposed to be on paternity leave. He's our lead informaticist, but his baby came a little early, so he's back with us. Jessica Whalen also just had a baby, different baby, but just came back with us. So we have an ever-expanding family at PEDSnet. And then the bottom row here, Maria, Amanda, Hannah, and Natasha are all folks that really help keep us going. Special gratitude to Mary. Mary really has championed PEDSnet at Stanford and has been there and really understands why we're doing what we're doing and has been very supportive of our efforts. Grace Lee was the first Stanford PI for the first 2 years that Stanford has been involved. Grace is now our Chief Quality Officer and passed this on to me, but really has blazed a lot of trails with her work as a Stanford PI. So just to share some Stanford successes thus far, Yair Bennett, I think I saw Yair somewhere back there, but Yair is completed something called the PEDSnet Scholars Program. So find Yair at lunch and hear what he has to say about that. Yair is also doing some really fascinating ongoing work around ADHD management in the primary care setting, and will continue to work with us on that. Kate Steffen down at the bottom right here is a colleague in the PICU who's received AHRQ R18 funding to do work in PEDSnet looking at red blood cell transfusions in the PICU, and is going to use the existing data to try to sort of describe current practices, and then is taking an implementation science approach to get us to stop doing unnecessary transfusions, which have quite a bit of harm and probably a carbon footprint, to steal from the last session. Susan Carmichael has been our representative for the maternal morbidity and mortality capacity building work group at PEDSnet, and a couple just publications that have come out led by our groups here. Priya Prahalad wrote a really important paper on using PEDSnet, looking at diabetes from COVID, and then Grace Lee was a key part of the team that looked at post-COVID phenomenon in children. So I just want to close by a quick cautionary tale about database research. And this is work that we recently did based on this paper that was published a year ago in JAMA Pediatrics using the FIS database. And Dr. Russell will talk about the FIS database a little bit later. But for those that haven't heard of it, it's 50 children's hospitals contribute all of their administrative data to Children's Hospital Association of America to, and can be used for research. There have been at least 1,300 publications from this database trying to answer these questions that we're not answering by randomized trials. So this paper looked at oseltamivir, Tamiflu, in kids hospitalized with influenza and suggested that kids who were diagnosed with influenza and got Tamiflu did better than kids who were diagnosed with influenza and didn't get Tamiflu. So when we saw this, we sort of asked ourselves, are we sure we're making the right comparisons? Are people in FIS that are labeled as having influenza and not getting Tamiflu really the patients we want to be studying here? And so we looked, this is just they used propensity matching in that paper to try to make the two groups even, and this is just a whimsical look at how sometimes propensity matching can get things wrong, because they can make Prince Charles and Ozzy Osbourne look like basically the same person if you just look at certain demographics. So we pulled charts at 3 different children's hospitals, at Boston Children's, Utah, and Stanford, of kids who in FIS would be labeled as having influenza by ICD codes and not getting Tamiflu. And we found that 63% of kids are wrongly classified. Okay, and mostly, this is where it got really interesting, it's mostly because they had para-influenza, same name, totally different virus, or Haemophilus influenza, which isn't even a virus, it's a bacteria, and something happens with coding where those names get sort of labeled as influenza as a primary discharge diagnosis, but they don't have influenza, so they shouldn't have gotten Tamiflu. And another whole bunch of kids got oseltamivir prior to admission. Again, something that maybe PEDSnet might be able to capture or claims data might be able to capture, but that a hospitalization database might not. Most importantly, misclassified kids had worse outcomes. So suggesting that the findings from this study, plus a couple of other studies that have suggested benefit from oseltamivir in influenza, may have been biased away from the null because of this misclassification issue. And Hannah Bassett led this work with us at Stanford. So the takeaway from this is not necessarily to dampen the enthusiasm around using large data sets, but just to make sure that we're conscious of how easy it is to make type 1 errors and prematurely reject the null hypothesis. Steve Goodman, I think, said this best in JAMA a couple years ago. Most problems are not solvable simply by enlarging data sets. They, in fact, can be worsened if high precision is reported around wrong answers, which is often misinterpreted as solid evidence. So, to summarize PEDSnet in today's sessions, there is a wealth of important data around us. PEDSnet brings an additional layer of granularity and can help us to answer incredibly important questions. But whether it's RCTs or other types of experimental designs should continue to really be our pie in the sky when we think at least about comparative effectiveness interventions. So I'm going to hand this over to Natalie now and look forward to hearing your questions afterwards. We also will be available at lunch to talk about all of these data sets as well.
Good. Great. Can y'all hear me? Thank you, Alan. So I am going to go into a different source of data directly from our EHR here and EPIC more broadly, and give you a little bit of an overview of what is available and how things continue to evolve. I'm starting with Slice or Dicer, which actually is not available for pure research use yet, so a little bit out of the theme, but to give you an idea of what this interface looks like, what types of information is available, and how it can support quality improvement work, and hopefully in the future also research work. So for those of you who don't know, Slice or Dicer is a self-service reporting tool within EPIC. And so we have, again, our own instance of EPIC at Stanford Children's Health. And this tool is available to anybody, any clinician or operational staff member who works in Epic. Using Slicer Dicer, users can find all sorts of data that they might have a question about. And so just to give you a couple examples, we recently had several of our clinical informaticists using some of our newer models in Slicer Dicer to answer some interesting questions. So our anesthesiology informaticists had been hearing about national trends with nitrous oxide having significant leakage. And so they used Slicer Dicer to look at the purchased nitrous oxide versus the actual use of nitrous oxide in the ORs and showed a significant gap, suggesting that there's a major issue with leakage. They're also trying to reduce nitrous oxide use because of some of the environmental effects, and so they've been using trends from Slicer Dicer to monitor whether those educational efforts have been effective. Similarly, with our hospitalist group, Whitney Chadwick, our associate CMIO, is amazing with Slicer Dicer and has been looking at things like what is our discharge time for patients with certain attendings or certain services in the hospital, so that we can try to do some of our quality improvement work there. So a few guidelines. So again, it is a self-service cohort discovery tool that right now is intended to facilitate direct patient care, hospital operations, and quality improvement. It is not right now approved here for IRB approved clinical research purposes, although we are in ongoing conversations so that for those of you who may be doing clinical work or operational work and see an obvious tie over to research, that we can make it easier to translate some of that clinical and operational improvement work directly into an IRB approved research study. PHI access using Slicer Dicer is governed by the same principles, HIPAA principles and rules that we have to think about anywhere in our clinical setting. And all searches executed as part of Slicer Dicer can be audited at any time from compliance. You, of course, should not share your login. And then finally, the best practice is if you are using Slicer Dicer is to save that session and cite it so that it can be recreated or reevaluated for exactly some of the reasons that Alan talks about, right? Whenever we're looking at these large data sets, there's always a risk that we are misinterpreting data or that it's not accurate. And so we want to be able to go back and investigate that if something doesn't make sense. Unfortunately, I'm not going to show the video because we're having trouble with getting access to that. So I'll just show you a couple quick pieces. There are videos and trainings, and I'm going to show you how to get there. But for those of you who work in our system in Epic, if you just go into Epic and under the main menu, go down to, oh my goodness, go down to reports, and then there's a Slicer Dicer menu. When you go into that, the first time you go in, you'll immediately get a tutorial. So there is some self-guided tutorials in there. We are rapidly working to expand the data models that are available. So for those of you who may have tried Slicer Dicer when we originally rolled this out, I don't know, about 7 or 8 years ago, we have been doing a ton of work recently to expand the number of models that are available. So definitely recommend you going back in now and checking it out. This is what it looks like. So you choose a population. You can slice your data by various metrics, by gender, by age, by whatever option you want in there. You can decide what kind of measures you want associated with that, averages, maxes, total numbers, that kind of thing. There's various visual options. You can specify relationships between different criteria, certain logic. And then again, for that clinical and operational use, if you are identifying a population that you want to do something with, so for example, maybe you're looking for all of your asthma patients who haven't yet got the flu vaccine, you can actually export that and then send them all a direct MyChart message. So take action on that in real time. All right. So that's the basics of Slicer Dicer. Again, not perfect for this form because it is not yet approved for research, but for those of you who are doing quality improvement work, it really is a powerful tool. And again, we are working to try to partner with our School of Medicine colleagues to get a process for being able to use that easily for research as well. But it is also the user interface that is going to power Cosmos. So just to let you guys know a little bit about this, and I'll say we are very early in our explorations here. Stanford Medicine is going live with Cosmos across both the SHC and Stanford Medicine Children's Health Systems. For those of you that don't know, Cosmos is a large database across any Epic site that is participating. that allows EPIC data across the country, across the world to be used for research. And they say improved clinical care. I think there's a lot of questions on that piece of it, but gives you access for research purposes, which I think is the real excitement here. So any organization that agrees to provide their data to Cosmos can participate and use that. We have just gone through the processes across Stanford Medicine to start providing our data. It is a very limited data set. What we are providing is not completely de-identified, but what a researcher gets access to is completely de-identified. So this is, again, limited. There's going to be limited use cases for this, but it is a huge number of records. So this is what EPIC puts out as their benefits. The benefits for using Cosmos, I think perhaps the most important is that bottom one, the faster access to data. So there are millions of records that are now available through Cosmos, and we're seeing more and more organizations beginning to join, including several children's hospitals, ours, of course, being one of the most notable, but there are a few other children's hospitals, and we're seeing a lot more interest from other children's hospitals. So we expect that to continue to grow. The data is already mapped and normalized across these organizations according to EPIC's processes, so some advantages there. But again, it is a limited data set, and I think there's a lot of work that we need to do to understand exactly what types of use cases will be appropriate for this tool versus PEDSnet, and I think that will continue to evolve. The other thing I'll mention, again, one of the things that EPIC is talking about is this integration back into care workflows. And there is a unique opportunity here because it is all within EPIC. The use cases they give is kind of this patients like mine idea, or for those of you who have used Atropos, same kind of thing where you can query your own EHR data to maybe think about how you might guide care. I think for all the reasons that Alan mentioned about the limitations of large data sets and not knowing exactly how to apply, or not being able to verify the validity of that, I think there's a lot of risk at doing that at the local level, but obviously work that we need to continue to do. There's also the opportunity to potentially identify rare patients, and so that you could possibly reach out to a colleague who has seen something similar if you're looking for somebody else to get guidance from. We're starting to see a few large articles being published in the peer-reviewed literature using Cosmos. So again, I think very early in this journey, but exciting, and lots more information to come on that. And that's all I have.
Hi everyone, I'm Natasha Flowers. I'm a biomedical informatics data scientist on the Research Technology Engineering Services team at Stanford Healthcare. And today I will be talking about STARR-OMOP, which is what we call the database containing Stanford's electronic health records in the OMOP Common Data Model format. So in order to explain what STARR-OMOP is and why it is so valuable to researchers, we first need to understand the broader context surrounding STARR-OMOP. So I split this into these two bubbles. We have STAR on one side, OMOP on the other, and these are both like research ecosystems in their own right. So STAR is Stanford specific, and OMOP is an open community common data model. It's used across many different institutions. It's actually really similar to the PEDSnet data model as well. Both of these research models come with a wealth of information and infrastructure. Part of the purpose of this slide is to show you that there's just a lot of stuff that exists in both of these. And I'm not going to focus on the specifics of all the examples here at the moment, but I want you to notice that, so in green we have raw data. That's only available to researchers through STAR, so like the Stanford data, but everything else is actually available through both. So we have analysis-ready data, both through STAR and through OMOP. We have tools that help researchers to access and analyze that data through both, and then we also have a lot of different kinds of user support that's available in-house at Stanford, as well as through the broader OMOP community. So STAR stands kind of, for Stanford Medicine Research Data Repository. I think they were really reaching. They really wanted the STAR acronym, and they were just going to make it work no matter what. So that's what the STAR theoretically stands for. And it is hard to describe exactly what STAR is because it does consist of these 4 different elements of the data in different forms, and then the tools, and then the support. The data sources that come into STAR are from SHC, the Adult Hospital, the Children's Hospital, and Tri-Valley. So it's from both of the EPIC instances at Stanford, the Adult and Children's. And it also includes in-house tools to support data extraction and analysis. This includes a cohort discovery tool that is built on Stanford's in-house data model, which was formerly known as STRIDE. We're not supposed to call it STRIDE anymore, but we don't have a great name for it, so it's just the in-house data model. And that allows pretty much anyone who has a Stanford ID to log in, enter a characteristic they're interested in, like a particular type of drug or a particular condition, and get an approximate count of patients at Stanford that have that condition. So it's a really low bar for getting some basic information about what's available for research at Stanford. We also offer user support in the form of YouTube tutorials, example code in a GitLab, office hours, and individual consults for more specific questions. So STARR-OMOP, which is the focus of the talk today, is one form of analysis-ready data. PEDSnet also falls under the category of analysis-ready data. OMOP stands for Observation Medical Outcomes Partnership. They were feeling a lot less creative with the acronym here than for STAR, so they just went with the traditional approach. And OMOP was the name of the original project that developed the common data model. It's now maintained by an organization called Odyssey. They also were getting creative with the acronyms. And so the data model specifies both the content and the structure of the relational database. So it says what kind of information should be brought in and where that information should be stored depending on the type of information. And it also specifies literally like what are the table names, what are the column names within each of those tables, and everything like that. So this means that tools or an analysis, like a set of code that is used to analyze the data, can be ported really easily between different sites. So you can start by developing it on one hospital's instance, and then you can extend that to 2, 3, 4, however many instances that are in this same common data model format as you have access to. And there are lots of different kinds of data that have already been transformed into OMOP. So we have there's lots of claims databases that are in OMOP. There's EHR databases. There's also data that's coming from like all around the world internationally. And obviously those data look very different at their source. And so the data model really allows us to be very efficient in our use of tools and analysis across all these different kinds of source data. STAR-OMOP, as should be clear by now, is Stanford's OMOP instance, and it contains data from Stanford hospitals in the CDM format. It's based off of Clarity, which is, I think you saw in Natalie's slides, that was one of the levels that's built on the EPIC EHR. And our STAR-OMOP instance is refreshed bi-weekly by my team, the engineering team that I work with closely. We include clinical notes, but those are refreshed monthly, and it is stored on Google Cloud Platform. It can be accessed directly through Google BigQuery on the cloud if you have someone on your team that knows a little bit of SQL, or indirectly through tools like Atlas and ACE. So Atlas is a cohort building and analysis tool that's available through OMOP, through the open community side of those two research bubbles. That it makes it a lot easier to define your cohorts and investigate them. And then ACE is something kind of similar that was developed in-house at Stanford that makes it really easy to define temporal relationships between events when you're defining your cohort. So who exactly is in OMOP? So we have very broad inclusion criteria for allowing patients from Stanford to enter our OMOP instance. They have to have at least one visit that has at least one associated clinical event, and that event can be a diagnosis, a procedure, a measurement, a prescription, anything along those lines. It is all ages, so it's including data from the adult and children's hospitals, and it's overall available calendar time that we have from our source EPIC data. So the data availability is a little bit limited for pre-EPIC calendar time. So for the Children's Hospital, that's pre-2014, just because not all of the data was ported over to the new EHR system. But if it's there, we are trying to bring it through in OMOP to make it available for research. So I have some basic demographics here. This is the data cut from October 7th, which was the most recent one that we put into production. And so you can see the age distribution here is mostly what I wanted to show. This is the age at the most recent visit for those patients. So you can see there are a lot of patients in OMOP that are in the age 0 to 19 category at their most recent visit. Then there's also older patients that do have data from when they were younger as well. So I do want to mention that this data, as it's most easily available to research, is in what we're calling a confidential data set, which means we have stripped out the majority of the identifying information. It's not meeting the criteria for a fully de-identified data set, so we're calling it confidential. But it is also possible to get access to identified data if you have a specific research need and an IRB that allows you to access that data directly. And we can provide cuts of data that link to the rest of OMOP so that you can get sort of just what you need for your particular research and then take advantage of the existing STARR-OMOP infrastructure for the rest. So now that we have a better understanding of STARR-OMOP, I wanted to zoom out again to our big Venn diagram here and look at a few other things that are available to researchers as part of these two ecosystems. So STARR-OMOP is not the only OMOP instance that is available to Stanford researchers. There is also an OMOP instance that is built on market scan data, which is a commercial claims database, and that's available through the Population Health Sciences, Center for Population Health Sciences, did I get that right? Not services, right? Sciences. And also the American Family Cohort OMOP is going to be available very soon, if not quite yet, to researchers, and that is containing data from our primary care provider registry that was established by the American Board of Family Medicine. And so both of those OMOPs, which are the same tables, same names and everything as our STARR-OMOP, they contain data from millions of patients across the whole US, and they're available to Stanford researchers through that Center for Population Health Sciences. I also wanted to mention again the in-house data model, STRIDE, which exists on the STARR side, and the tools that are built on that. So this is what we typically refer to as STARR tools. That includes the cohort discovery tool that I mentioned earlier, and then also a chart review tool that's available if you have an IRB to make it easier for researchers to go through and examine data for specific patients. And both of those are currently being adapted to be able to run on STARR-OMOP in addition to the in-house data models. So the set of tools available to researchers using STAR-OMOP at Stanford is continuing to expand. So that is all I've got for now. Thank you very much for your time, and I look forward to answering any questions during the panel.
All right. Thank you so much. I'm Esther Velasquez. As Alan mentioned at the beginning, I'm a research scientist at the Center for Population Health Sciences. This is a good segue after Natasha's presentation because I'll kind of expand on some of the things that the OMOP team has done in conjunction with our team and how those resources can be available to all of you. So if you are unfamiliar with PHS, I'll kind of provide you with a brief overview of what it is that we can do, how all of you can be involved in the work that we're doing or lead your own work at our center. And then we'll talk a little bit about some data assets that we have available to researchers. So really the focus of our work is to catalyze health equity. That's kind of our local focus. We're harnessing real world data, and then collaboration is at the key of what we're doing. And so for us, collaboration really has kind of a broad spectrum. So we're working with students and faculty, both at Stanford and externally, federal institutions, professional agencies, local public health departments, a very wide span of people that can be involved in this work. I'm going to use a data lake metaphor. Some of you may be familiar with that to kind of talk about what the workflow process looks like at PHS and kind of where our work is and where you can kind of join in and get involved in that. And so if you think about an actual lake, you have this very dynamic system. Water is constantly flowing into the system and flowing out of the system. Lots of activity underneath the water, at the surface, on the water's edge. So when we think about this for data and the Center for Population Health Sciences, what we're doing is we're gathering all of this real-world data. And by real-world data, I mean data that isn't collected in a simulated environment. So usually it's collected for other purposes like claims data, EHR, or electronic health record data. Could be tax data, could be educational data, could be air pollution data, all the kinds of data. We're gathering, collecting them, and then we store them in secure computational environments at Stanford behind their firewall that are HIPAA compliant. We make them available to researchers in different types of formats, and the purpose for that is because we understand researchers have different types of computational needs, and also there's such a diverse array of experience and skill set. So we try to kind of have something for everyone in that space. So the next part is still kind of thinking about what's happening below the surface of the water and what we're doing behind the scenes for all of you. And so we do a lot of data enhancement, so lots and lots of data cleaning. We do data linkages, so some of our data sets we've linked to census data. They're one of our partners. We've linked to pneumodent death data as well. And so building variables that then become available to all of you to use in your research as well. So I guess the last thing, again, I'll just mention is this collaboration piece, which is where we're doing our own research. We're collaborating with partners and researchers to do research, and then the goal and the idea is then to disseminate that back out into the world and share the findings. So I'll focus on 3 data sets that I selected out of the data sets we have that I think are particularly useful for pediatric and maternal health research. So we'll go through them. The first 2 are both claims data sets, so Medicaid and Market Scan that Natasha mentioned. And then this last one Natasha mentioned as well, I'll give you a little bit more information about it. It's an electronic health record system. So Medicaid, most of you are probably familiar with that. So all the individuals in this data set are Medicaid enrollees. So just as a reminder, Medicaid is a joint federal and state program. So the benefits and eligibility do vary somewhat by state. But generally speaking, we're talking about low-income individuals and families, pregnant women, children, and individuals with disability. I think a huge advantage of the data set that we have at Stanford is that we have a big chunk of data. So 2011 to 2019, we have 100% coverage. That means every single person in the United States that had Medicaid or was in a Medicaid enrollee any time in that period is in this data set. So a great resource for all of you that are interested in clinical questions and policy questions, health research questions. So this data set is going to have demographic information, inpatient, outpatient, long-term care, drug information, and then kind of like an other grouping, which will include a whole range of things from like procedures and x-rays, ABA therapy, speech therapy, dental care. So kind of huge overview of the type of care that people are receiving. So I guess the last thing I want to mention with this data set is I just wanted to provide an example of some projects happening at Stanford using this data set. I think they highlight the strengths of the data set nicely. So this first one is looking at the well-being of immigrant parents and their newborns. So through emergency Medicaid, undocumented immigrants are able to access care. And so this is really capitalizing on that to identify their sample of undocumented immigrants. And then we have about 1.7 to 2 million newborns in our data set annually, really large sample size. So that creates a great opportunity for this team to answer their research question. Similarly, in this next question, so Medicaid is this great resource for having wealth of sociodemographic information as well as medical information in the same data set. So they're looking at individuals they identify as doubly disadvantaged. And so for their definition, that includes individuals, let's see, low income, having a disability, being part of a racially minoritized group, or immigrant status. And then this last one goes nicely with the session from this morning. So Medicaid has a very small geographic unit. We know the census tract that every patient lives in. So using that information, you can estimate the environmental contaminants someone could possibly have been exposed to in their home. So air pollution, water pollution, extreme heat. Those of you that are also interested in geopolitical issues or neighborhood deprivation, this could be a good data set as well. So I'll spend a little less time on the last 2. Do just want to make you all aware of them. So Market Scan, which was mentioned earlier, is also a claims database. So whereas Medicaid is entirely public, Market Scan is a commercially insured data set. And so all the individuals in Market Scan are employed with private insurance through their employer. And then the data set also has all of the dependents that are covered on that plan. And so that's why we have about 52 million youth. So just with these data sets, you're just getting very large sample sizes. This is a great option if you're someone that does rare outcomes or more common outcomes, but in a specific subpopulation. Also, this longitudinal follow-up allows you to just see over time how things have changed, how treatment has changed, how policy has changed. And then just keep in mind, the public data sets are a little bit slower. CMS just takes longer to push out new data. And so if you're someone that's thinking, I really need data in the last year, you're going to want to look at most likely one of the data sets mentioned earlier, or a commercially insured data set. Oh, and then, there's two last things I want to mention. So one is that claims are great for universal capture of care. So a lot of times we're just seeing care in one health system or one type of care, so just dental care. But in the claim, you can see all the billed services. So if you're looking at a kiddo, you can see, did they get a dental checkup? Did they go to their pediatrician? What about that flu shot that they got at the retail pharmacy? They're also having speech therapy. You're going to see that whole breadth of all of those services in one place. It's a great advantage. And then there's also cost information. We do have individuals in economics and health services very interested in the cost for these, which is available. So I'll skip through these examples. The last thing I wanted to leave you with is this electronic health record data set we have, the American Family Cohort. Natasha mentioned that it's also an OMOP, and so any code that you would develop or your team develops for one of those data sets, you could use it on this as well. So this is a unique data set in that they're all primary care practices. We have patients in all 50 states. One thing that's interesting about this data set is that these practices participate in PRIME Registry, which is managed by the American Board of Family Medicine. So they tend to be practices that have an incentive to participate in the registry, which compiles their data and to submit to CMS for quality indicators, which allows them to bill for Medicaid and Medicare. So these are smaller practices, private practices, not at Stanford, not at large healthcare or academic centers. So it's a different population. It will include patients that have public insurance and private insurance, and quite a bit of children still. We have about 900,000 under the age of 18, and we refresh it about every 6 months. We do have a number of, I didn't have this included here, but I will just mention we do have unstructured data, so we do have progress notes. We do have a number of Stanford researchers that are using it for natural language processing, trying to pull out information about what's included in those notes, as well as what's in the structured data, so diagnoses, drugs, demographics, all that kind of stuff. So the last thing, and I know I've thrown a lot of information at you, so take a screenshot of this if you want. So data and data access are two websites you can go to find out more about the data sets that we have at PHS that you can all access. Data access is going to walk you through step by step of how you actually get access to these data sets. And then please do sign up for our office hours or reach out to us. Part of the purpose of our center is to get people like you using our data, so it's a main goal of ours as well. So happy to answer any questions during the panel, and I hope that I hear from some of you in the future as well. Thank you.
Good morning, everyone. My name is Christopher Russell. I'm a relatively new faculty member, as Dr. Schroeder said, in the Department of Pediatrics and the Division of Hospital Medicine. And I am really thankful for the opportunity and to talk a little bit about some of the data sets that I use on a regular basis for my health services research. So we're going to focus on three main data sets that are generally available and publicly available. The first one is going to be the Kids Inpatient Database, and the second one is called the National Inpatient Sample. And these are really two similar data sets that are developed by the HCUP, so the Healthcare Quality and Utilization Project in AHRQ. And this slide, and then we're going to sort of in the end talk about the Pediatric Health Information Systems data set, or PHIS, which is run by the Children's Hospital Association. And this slide sort of does a very high-level comparison of them. The HCUP data sets and the PHIS data set all have both emergency data, they have inpatient data, and they have some limited surgical, including ambulatory surgery data. And what the main difference of these data sets is sort of the granularity of data and also your ability to be able to answer questions and population level questions, which is what I'm going to talk about a little bit today. So the first one I'm going to briefly mention is the Kids Inpatient Database, which is, as I said, run by AHRQ. And I think what's unique about this data set is they are the only all-payer claims data set for inpatient data. So that means, unlike what was discussed earlier, these data sets really include all payer mixes. So we're not separating out private payers, public payers, and then trying to compare them or do research projects where we're combining those data sets. And it includes 3 million hospitalizations from nearly all of the states in the United States and the District of Columbia, and includes patients up to 21 years old. The challenge with this data set is it's pretty high level. It includes some diagnoses and procedures. It has codes about where patients were discharged to, limited demographics and hospital characteristics, who's paying for the hospitalization, some charge data, length of stay, and some severity data. And I want to point out, because we were looking at some of those other in the previous talks, really paying attention to the race and ethnicity data and the percent missing. And so they try to do their best about minimizing that. But even in this data set, we have fairly high proportions of people who have other race or other ethnicities reported, which makes it hard to do some of our health equity work that we'd like to examine. Really for this data set, I wanted to. One of the key things about this is that this includes community hospitals, and 70% of children are cared for at community hospitals, including both children with bread and butter, typical pediatrics diseases, as well as children who have medical technology dependence and medical complexity. So this really allows us to integrate the children's hospitals and the community hospitals. And it actually samples 80% of all of pediatric discharges. So it's representative of most of the discharges. One thing that this allows for that's unique compared to many of the other data sets is it allows for population estimates. So it gives you a weighting characteristic that allows you to do population estimates of a disease and then allows you to do trends across years. And as I said, it includes all insurance types because it's an all-payer claims data. But there are disadvantages with it. You saw the variables that were included. It's very high level. We're doing like rudimentary, the length of stay for this group is higher than the other one, or the costs are higher or lower. And the other thing it does is that it comes out every 3 years. So you can see it skipped the last one came out in 2019, and it skipped a pivotal few years where COVID impacted us, and we're not going to be able to really see trends when these acute events happen. But I think this is a really good data set, particularly for trainees or other people who are just trying to get an understanding of what a disease might look like for patients in a hospitalized setting, what have been the high-level trends, and are we seeing any signals about differences in groups to figuring out how to do more robust randomized clinical trials or more robust study designs. The national inpatient sample, I'm not going to spend a lot of time on, but it's KID, so it's the same data set we just talked about in design and variables, but it includes all ages, so it includes adults and children, and it's weighted, again, you can see has 7,000 admissions, but the difference is that it doesn't cover nearly as many pediatric hospitals and admissions as the previous data set. It only samples about 20% of hospitalizations across the United States and the District of Columbia. We do find that they actually are very similar, and when you compare KID, which is really pediatric focused, to this more generalized one, the data is pretty similar in terms of discharge counts and length of stay when you have higher volume admissions. So for those rare diseases, KID is probably the more appropriate data set. But the main advantage for this data set is it's a yearly release. So it gets released every year, so you may not have the volume of pediatric admissions. You can weight them, but you have the ability to compare across years. The final data set, and this is the one that I'm going to spend a little bit of time talking about, is called the Pediatric Health Information Systems data set. So this is a collaboration that is really run out of the Children's Hospital Association, which includes more than 50 freestanding children's hospitals in the United States, millions of inpatient cases a year that are cared for at those hospitals, millions of inpatient days, and in addition includes a lot of emergency room encounters, where the majority of the hospitals include that. And this is managed by the Children's Hospital Association. So as a member hospital, we get the benefit of being able to use this data and use it not just for research purposes like we're discussing today, but a lot of children's hospitals are using this to benchmark themselves when you're looking at days of antibiotic therapy, albuterol use in bronchiolitis. So some of these quality measures, you can benchmark yourself against children's hospitals of the same volume, caliber, region of the country. What FIS does is it takes, it sort of has this, probably proprietary, where they take inpatient data, ambulatory surgery data, the emergency room department, and then if you have an observation unit in your hospital. And it integrates both, because it's administrative data, it integrates the information in the medical record and the billing system, and then it dumps it into this data set. These are the select hospitals. It's a little bit out of date, but we are a member at Lewis Backward Children's Hospital. And I think the other thing that key advantages is it's all de-identified, so any research that's done with this without unblinding a patient is usually exempt research from the IRB. So how does this work? Well, really what's collected at each patient encounter. So you have a patient come into one of those 4 settings that I mentioned above. We have information, it's now ICD-10 coding, but we have some patient abstract information, their demographics, their insurance status, up to 41 diagnoses and procedures that they might have had. And this gets fed into this sort of proprietary way where they have hospital IDs that are, that each hospital has a unique ID. You have a masked MRM that the hospital, at its hospital level, can be unmasked, and therefore you can go to the medical record chart and look for more detailed data. Common things that are collected is there, including that masked MRM. And then they take all the pharmacy data, the imaging, radiology, labs, clinical supplies. So if you want to know if a patient was on high flow, you look to see if they had a billing encounter for high flow or if they got charged for some of the equipment related to high flow. All of this is just administrative data, so we don't have lab results and radiology results, which is where PEDSnet comes in and all these other data sets. But we have this FIS has the advantage of being 50+ children's hospitals. And so basically, just to demonstrate it very clearly, this is what happens. If they want to take vancomycin and you're getting 125 milligrams of vancomycin, hospital A does it one way, hospital B has a totally different code. And what FIS does is it takes these disparate ways of measuring vancomycin and sort of breaks it down to create this common language that says this 12-digit or 13-digit number means 125 milligrams of vancomycin. So just thinking about, so you can actually see the doses of the medications that were ordered and uncharged, or billed for, I guess. And it becomes this CTC code that is common across all the hospitals. So I'll close with the main advantages of this data set. It's really detailed data available. CHA does a great job with data quality. It's released on a quarterly basis. It allows for benchmarking across children's hospitals. And that unique patient identifier allows you to follow patients in their inpatient hospitalization across hospitalizations and for readmissions for the same hospital. And usually, like I said, it's IRB exempt. The main disadvantage is it only represents freestanding children's hospitals. They don't have that granular data that's needed, like the number of medication doses, those results, which can be really helpful. Can't provide population estimates, and it only measures same hospital readmission. So if a patient goes to a community hospital or a different children's hospital for a readmission, it's not captured here. FIS and KID have pretty similar sort of volumes of admission, so you can sort of see the top 10 diagnoses in sort of freestanding children's hospitals versus non-freestanding children's hospitals here. So the problem with that is that, remembering FIS is a freestanding children's hospital. So there's a little bit of a difference in terms of what is represented in terms of diseases. So you want to think about which data set is the right one depending on what kind of diseases you're studying. I'll briefly just mention the nationwide readmissions data set, which basically is helping to, as a unique data set to allow us to look at readmissions, which is built off of AHRQ's data sets that we talked about earlier. But it allows you to look at readmissions not just at that one hospital, but across different hospitals within a state. So I think I'll just close by saying there's a lot of different databases, the ones I mentioned, the ones that have been already mentioned for pediatric research. I think my big take home would be it's really critical to understand the advantages and limitations of the data set that you're thinking about using to identify that and select that ideal data set for, to complete your appropriate analyses. And there are other data sets that have been talked about that allow for longitudinal cohorts and inpatient-outpatient comparisons, but they often are limited to one insurance or payer type. So with that, I think we're going to start with the panel, right? Thank you.
As everyone comes on up to the front here, please start thinking about your questions. And I just wanted to add, as exhaustive of a tour as that was of all of the data sources that we have at Stanford, there are so many more. And each subspecialty has their own collaboration and their own resources to use. There are other national data sets for primary care, outpatient care, like NHANES and NAMCIS and other things like that. So this was meant to be an overview, but obviously there's a lot more out there. One of the things that I hope to do at PEDSnet, Chris is going to help with this, I think Esther at PHS, and certainly Natalie and her group in Informatics, is come and just ask us questions at any time, not just today, about what you wanna do, and we will try to help you get you to the right data source. So looks like we have some questions. Go ahead.
Hi, thank you all so much. I was wondering if you could comment on the feasibility of linking mothers and their children, their health records, in case we're interested in prenatal health.
Do you want to talk about PEDSnet?
Sure, I can speak to that. So as Alan mentioned, Keith Morse, co-site PI for PEDSnet, and we are actually participating in a project now where we are attempting to do just that. We at Stanford happen to be very lucky where we are obviously a pediatric and maternal institution, so it's very easy for us. Outside of us, it is site dependent on what type of relationships they have with OB departments. Some have formal research relationships where it's relatively easy, but it is not straightforward for the most part from a PEDSnet standpoint.
I can comment. So in Medicaid, we are currently developing an algorithm to link moms and babies. It is not straightforward. In MarketScan, there is a family variable, so you can see everyone that's in the family. That could be, you wouldn't necessarily know is a biological child or an adopted child. So there are some limitations. It depends like how far back you could see in things, but there's some.
One of the things that I learned, I was surprised it took me this long to learn, and I didn't learn this until I took my role at PEDSnet, but Stanford is unusual in that most babies are born here. Most other children's hospitals don't have maternity. And so they have NICUs, but they don't have well baby nurseries. And so that makes, actually for PEDSnet, makes Stanford quite coveted because we have all that data. Mary.
Oh, thank you. So, Chris, my favorite part of the presentation is when you pointed on the list of children's hospitals and you pointed to us and you said we. So welcome. We're so happy you're here. So happy you're here. Boy, I have a lot of questions, and I think most of it's just very, very practical. So the first is, Natalie will remember well, was probably 4 or 5 years ago when we said, okay, how are we going to get in PEDSnet? At that point, PEDSnet had been funded just 8 children's hospitals as a single grant. And it took many years and, frankly, many hundreds of thousands of dollars of staff and the effort to get in and the regulatory and everything, and to break through and become the first new children's hospital after the original 8. And I think after we and really a testimony to Grace's dedication, broke down a lot of those barriers and the governance and all of that. Now there's other ones that are following. Natalie will remember, for the day we started thinking about this, we thought, okay, do we have the people here that will know how to use it? Because really the return on investment is the big things like the RO1s. And so MCH and Kate Stephan, we're so proud of having the first R really on her work on in ICU and implementation science and transfusions. So MCHRI really wants to make sure we're able to help our faculty and people on this campus use PEDSnet effectively to really do high impact research. So the first question is, Keith and Alan, if you think you want to do a study in PEDSnet, what sort of barriers, like for instance, you need preliminary data. Do you have to pay for it? Who does the analyses? Can you get your hands into the data? So just thinking through a little bit of the mechanics. Maybe I'll start there because I had a couple other related questions. But let's imagine someone has an idea for a big study they want to do in PEDSnet, but they're going to need preliminary data. And how feasible is that? And do you need money? Because Alan, you said one of the things we were going to talk about today is, do you need money to be able to do these things? So let's start there.
Yeah, definitely. So the initial process is sort of two steps. One is it's probably best to come chat with Alan or myself, only to sort of get a sense of what the research question is and how well it's suited for PEDSnet. Assuming it is suited well for what PEDSnet can offer, the network has a service for where they call it a feasibility study, where essentially pre-funding they will pull a cohort of Table 1 statistics of patients who meet your criteria, with the thinking that that can go into your subsequent grant application. Because we have those two sort of filtering steps, or you could describe it as the support starts before the money is there, we have something like a 51% success rate with grants. And so we don't have those steps to be sort of stingy about what happens with the data, but it's intended to support the process.
Another question, another practical question, and I'm asking these because I don't know the answers, not because I'm planting them. Pathology reports, imaging, things that right now are free text. How good are those data?
Not good.
Not good. And can you get someone from Stanford to help you do natural language processing to get out of those what you need, or machine learning?
You can, if you have access to that data from Stanford or some other source. We don't have those skills as sort of turnkey within the PEDSnet team. You're touching on sort of I think a fundamental kind of characteristic of how you would potentially decide which resource to use among this. And that's around sort of granularity and what control you have if you need a little bit more granularity. The smaller the data sets, typically the easier it is to add on one or two other data sources, whether it's imaging data, whether it's free text. The huge data sets, Cosmos, like you have no control over what if you need to add things onto those.
And then one last question. So the other thing is, or maybe you wanted to expand
Well,
on
I
that,
wanted to
Alan?
just quickly
Yeah.
build on the first question because I think it's really important and thinks about our broader vision here for PEDSnet. And just to be perfectly frank, right now you gotta have funding to do work in PEDSnet. So we just gotta say that, right?
Yeah.
You need funding, but that's part of why we put this together today, so that you can use all of these other data sources, whether it's Packard data, whether it's some of these nationally available data sets like FIS or KID, whether it's even claims data, and you can talk maybe about how much that stuff costs later, but you can use those data sources to get your first papers, get your preliminary data, and then work with us to get funding to do the project through PEDSnet. So, but do come and talk to us so that we can help map that out for you. Sorry, go ahead.
Yeah. Oh, please.
Sorry, just, I mean, a practical example of what you're asking right now is we're trying to build a sort of learning health system or working group on children who have tracheostomy and ventilator assistance across. So we have 5 of us who have been meeting for like the last few months, just trying to develop how we might identify these patients in PEDSnet. And Cincinnati, one of the leads in Cincinnati is a pulmonologist, so he's been helping that. But the goal is really to develop some preliminary data with some Table 1s to be able to submit an R looking at this, in the next 6 to 12 months. So I think it's there are some resources to get, like Keith was saying, to get some preliminary data that I think is enough to sometimes justify that you're able to do the study and that there's a signal there.
That's great. And the other thing is, MCHRI, I hope everyone knows, funds master's tuition. I think I've said that twice already today. And we've funded fellows in maternal fetal medicine, anesthesia, and multiple different disciplines. But really, when you're doing your master's degree, nothing beats getting your hands in the data and running all analyses yourself. And that's where NHANES has been really brilliant for a lot of people's master's theses. For all the other data sets that were mentioned, with the exception of, I know, the issues with PEDSnet, everything else, a trainee can get their hands on the actual data, right, and do everything themselves. Free, for all intents and purposes.
Yeah, like a few hundred. Kid is a few $100.
Yeah, okay.
It's not like it's not cost prohibitive.
So
I think
feasible
your
for
data sets are
master's
probably.
theses and fellowship projects.
Yeah.
Phys has been harder than I would like it to be.
I mentored
and we'd
one
like
master's
it.
student using
We'd
Phys.
like it to
It's
be easier,
clunky.
but it's been
Yeah.
easier at other institutions, so we'd like to make it easier here. But yes, to otherwise answer your question.
All right, great. Well, thank you for those very practical answers. Thanks.
Along the same lines of
Just introduce yourself.
Oh, sorry. I'm Hector. I'm one of the pediatric endocrinology fellows. So we deal a lot, obviously, with patients with diabetes. Precision medicine is something that we're looking at more and more. I was curious of the status of genetic data in any of these.
Not present in PEDSnet.
Sorry.
Or
No,
any
no
future.
Yeah, by genetic data, tell us what you mean by genetic data.
Sure. Like genetic array data, or if somebody has a whole genome sequence performed, is that going to be ever a part of this, or is any work being done for that?
Not part of the current discussion, and part of the reason is institutions share data when they can be quite confident that the privacy of their patients is protected, and so that's part of the reason why notes has not been included in PEDSnet. It's really hard to, with confidence, protect anonymity. I have no idea what the process for scrubbing genetic data to preserve anonymity is like, and so you have to sort of think about. It would be great if we could do that, but the privacy offices of 11 institutions have to be on board with that, and that is not a trivial barrier, for good reason.
But you could use billing codes for sequencing to identify patients locally and then find someone to do your chart reviews. But getting it immediately at your fingertips would be hard.
That's great. Thank you.
Hi, I'm Aisha Manyar. I'm a pediatric nephrology fellow. I am currently working on developing my project for the master's program that Mary was talking about. Two questions I had. Number one, is there a way to extract kidney transplant donor data, typically from the adult side, and link that with the recipient data if you have the UNOS ID of the two? And secondly, I'm looking at blood pressure control post-transplant. So is there a way to, or one of the sources that would be best to extract granular inpatient blood pressure measurements as well as outpatient clinic measurements together?
Someone else can take the first one.
Yeah.
The second one, PEDSnet would be great.
Yeah.
I mean, PEDSnet has vital sign data on children, and if we could find who got transplanted, you could get their vital sign data from 11 children's hospitals. Probably the 11 children's hospitals that do some of the most renal transplants in the country. So I don't know what UNOS has, but probably not that level of granularity. So I think, but as far as linking to the donor.
Yeah, I think the barriers for donor linkage are similar to maternal pediatric data in the sense that for institutions with whom have a relationship with both the donor and the patient, potentially that kind of thing is not formally involved in PEDSnet because we don't really have a mechanism for adults who receive care at presumably most adult sites. And then the other element this sort of brings up is that it is possible that the characteristics of the donor are present in the record of the recipient, unstructured notes, those sorts of things. You run into all sorts of privacy issues with that because for the most part, those types of unstructured reports or characteristics weren't consented to by the donor. And so things that are sort of agreements that are based on the patients don't cover the the donor in terms of permission to share. So it's really hard for us to sort of support the surfacing of that information. The other example that comes up all the time is pediatric data or pediatric notes that have information about the mom in the pediatric record. Mom didn't consent to share her records or her history when the child had his or her record shared. So those are, again, linking, being creative and tricky about identifying linked information is problematic sometimes.
Thanks for the question. Time for, I think, one more, maybe two. No, go ahead.
Hi, Anne from Allergy Immunology. The last I had checked, I think STRIDE and STAR did not have the allergy section of the EMR, that you had to go through just keyword searches. I was wondering if, besides Slice or Dicer, if any of these databases contain the allergy section from EMR data?
I'm actually not sure if we've added that since the last time you checked. I can check on that. If you reach out to STARR-OMOP support, I can confirm that for you.
It's a great question because, I mean, particularly when you think about penicillin allergy delabeling, that type of stuff, we really should be pushing to have that data if we don't.
Maybe a follow-up. Can you talk about if something is not presently in STARR-OMOP and somebody out here wants it, what is the process for that, and is that possible?
Yeah, for sure. So if you reach out to us and we think that it's something that fits within the existing STAR-OMOP model, but we just haven't currently brought it into our STAR-OMOP here, and we think it's valuable to researchers in general, then we will do that as part of our ongoing maintenance and development, and it won't cost anything. If it's something that's very specific to a particular research project and it's not going to sort of benefit our overall STAR-OMOP instance, then there will probably be a charge for that work, or you might get it as like a side table that you can connect to OMOP. But in general, if it's something that will just help continuously improve our STAR-OMOP data model, we are totally willing to work with you to bring that in.
I've been told we have to have a hard stop, so I apologize. Please come talk to us. We'll be around for lunch, but the posters are next, and we want to make sure that the posters get all sorts of visibility too, so go look at the posters. Thank you all. Thank you to the panelists.